Assalamu alaikum. Today I'll be sharing with you a topic on identifying mental health conditions which require referral. Psychological distress, if left untreated, will lead to detrimental outcome. It may lead to psychiatric illnesses such as depression, anxiety disorders, and post-traumatic stress disorder. Frequently, victims of this psychological distress experience disruptions in reasonable mastery of the environment, in carrying attachments to others, and in sustaining a purposeful meaning in life. The impact of psychological distress may be profound and may last until death if these events are left untreated. So therefore, we have to refer one of the commonest psychiatric illness, which is depressive disorders. Depressive symptoms which need to be noted as part of depressive disorders if the symptoms persisted for more than 2 weeks, according to Diagnostic and Statistical Manual, the 5th editions, diagnostic criteria. The first criteria for the diagnosis of depressive disorder is presence of depressed mood most of the day, nearly every day. But we have to take note that in children and adolescents, this can be presented as irritable mood instead of depressed mood. The second criteria is the presence of markedly diminished interest or pleasure in all or almost all activities, most of the day, nearly every day. The third criteria is presence of significant weight loss when not dieting, or weight gain, or decrease or increase in appetite nearly every day. The fourth criteria is the presence of insomnia or hypersomnia nearly every day. Fifth criteria is presence of psychomotor agitation or retardation nearly every day, which should be observable by others and not merely subjective feelings of restlessness or being slowed down. The sixth criteria is presence of fatigue or loss of energy nearly every day. Seventh criteria is the presence of feelings of worthlessness or excessive or inappropriate guilt nearly every day. Eighth criteria is the presence of diminished ability to think or concentrate or indecisiveness nearly every day. And the most severe symptom is actually the ninth criteria, which could be presented as recurrent thoughts of death, not just fear of dying, but having passive death wishes, recurrent suicidal ideation without a specific plan, or a suicidal attempt, or a specific plan for committing suicide. There must be presence of at least 5 diagnostic criteria in order for us to diagnose depressive disorder. In addition to the diagnostic criteria, there should also be presence of symptoms causing clinically significant distress or impairment in social, occupational, or other important areas of functioning. Then we move on to the second psychiatric illness that requires referral, which is anxiety disorder. In terms of anxiety disorders, there are the clinical features which we have to take note of in order to identify the possibility of referral to psychiatrists according to DSM-5, which include the first criteria is the presence of excessive anxiety and worried about a variety of topics, events, or activities. The worry occurs more often than not for at least 6 months and is clearly excessive. For example, excessive worries means worrying even when there is nothing wrong or in a matter that is disproportionate to the actual risk. In adults, the worry can be about job responsibilities or performance, one's own health or the health of family members, financial matters, and other everyday typical life circumstances. However, in children, the worry is more likely to be about their abilities or the quality of their performance, for example, in school. The second criteria that we have to take note of for identifying anxiety disorder is the presence of recurrent unexpected panic attacks, which should be characterized by at least 4 or more symptoms, such as palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, a feeling of choking, chest pain or discomfort, nausea, abdominal distress, feeling dizzy, unsteadiness, lightheadedness or fainting, feelings of unreality, which is known as derealization, or being detached from oneself, which is known as depersonalization, fear of losing control or going crazy, fear of dying, numbness or tingling sensations, which is known as paresthesia, chills or hot flushes, and in addition, at least one attack is followed by 1 month or more of the person feeling that they will have more attacks coming in. The third diagnostic criteria that we have to take note of is the presence of experience of intense fear or anxiety in a minimum of 2 situations, being out in public, open spaces, or in crowds, especially anywhere in which you are outside of the home. And the final criteria that we have to take note of is the presence of persistent fear of 1 or more social or performance situations in which the person is exposed to unfamiliar people or the possibility being scrutinized by others, and the individual fear that he or she will act is in a way of showing anxiety symptoms that will be embarrassing and humiliating. So exposure to the fear situation almost invariably will provoke anxiety, which may take the form of a situational bound or situationally predisposed panic attack. The feared situations are avoided, or else they will be endured with intense anxiety and distress. And besides anxiety disorder, another psychiatric illness that will actually warrant referral to psychiatrists is actually the presence of post-traumatic stress disorder. In terms of post-traumatic stress disorder, there must be presence of traumatic event that is persistently re-experienced in 1 or more of the following way. Example, presence of recurrent, involuntary and intrusive memories, traumatic nightmares, dissociative reactions such as flashbacks, which may occur on a continuum from brief episodes to complete loss of consciousness, intense or prolonged distress after exposure to the traumatic reminders, marked physiological reactivity after exposure to trauma-related stimuli, persistent effortful avoidance of distressing trauma-related stimuli after the event as evidenced by 1 or more of the following, such as trauma-related thoughts or feelings, trauma-related external reminders, for example, people, places, conversations, activities, objects or situations that will remind the person of the traumatic event. And in addition, presence of negative alterations in cognitions and mood that begin or worsen after the traumatic events as evidenced by 2 or more of the following, such as inability to recall key features of the traumatic event, which usually presented as dissociative amnesia, which is of course not due to head injury or not due to any alcohol or drug consumption. And there should also be persistent and often distorted negative beliefs and expectations about oneself or the world. For example, one may think that he is bad, okay, and the world is completely dangerous. There may be persistent, distorted blame or self or others for causing the traumatic event, for resulting consequences. There may be persistent negative trauma-related emotions, for example, fear, horror, anger, guilt, or shame, or markedly diminished interest in the pre-traumatic significant activities, which include the hobby of a person after the experience of the post-traumatic stress disorder. Some patients may present with feeling alienated from others, example, detachment or entrenchment, and also having constricted affect, persistent ability to experience positive emotions. And finally, the final criteria is where there is presence of traumatic related alterations in arousal and reactivity that begin or worsen after the traumatic event, as evidenced by 2 or more of the following, such as irritable or aggressive behavior, self-destructive or reckless behaviors, hypervigilance, exaggerated startle response, problems in concentration, as well as sleep disturbance.